I thought I'd start this presentation with something a little bit different, a little bit interesting, to beat the post-lunch, snoozy effect. Have you guys ever heard that song? It's a really popular R&B song from back in the day. It's called "If I Ever Fall in Love" by Shy. No?
Can you sing a little bit?
It goes something like this. Ooh, da-doo-doo, doo-doo, ooh, da-doo-doo. The very first time that I saw your eyes, your lips said hello and I said hi. I knew right then you were the one. And if I ever fall in love again, I will be sure that the lady is a friend. And if I ever fall in love so true, I will be sure that the lady's just like you.
Good job, Dr. Datta.
Today I'm going to be talking about a subject called empathic history taking. So taking a history, getting to know a patient from the heart, and why it helps reduce recidivism. And what is recidivism? That's when you treat a patient, they're in the hospital, and they fall through the cracks. They don't get to the clinic. Or when they're in between clinics, they fall through the cracks and they don't get to clinic B. Or they're being released from corrections and they just don't get to the clinic. So why does this happen? And a lot of times it happens because the patients, they lose motivation. They're like, oh, mental health is not gonna help me. Psychiatry, psychology, counseling is not, oh, it's the same thing all over again. So what do we do to prevent these things falling through the cracks? And this presentation is about how to take a history so that the patient feels understood. So there's three objectives. How to genuinely understand the patient. So when you take a history, you're not just taking a dry history. You're really helping the patient see their strengths and weaknesses. It helps the clinician's empathic skills. And what is empathy? Sympathy and empathy are a little bit different. Empathy is like a little bit deeper than sympathy. Empathy is like you are understanding the patient's emotional plight. The empathy is a little bit deeper than sympathy. So I'm going to run through a hypothetical history. And in the process of the history, I hope I don't offend anybody. It's not my intention. But I'm going to mention, there's a few maybe blanket statements in there, just to make a point. I'm also going to tease out some different diagnoses. And the point of empathic history taking is, it is the fundamental of psychotherapy. Do we have psychotherapists in the room? Or social workers? Anybody who does something like therapy in their work? Something like that? Well, that's the point of this presentation. If you know how to take a history like this, then you are going to be doing psychotherapy for the patient. There's going to be some healing involved. And at the end of the presentation, I'm going to show you how you take this history and how you present it in 7 sentences so that the transfer process is easy. Whether the patient is coming from hospital, from corrections, clinic to clinic, how the doctor or the provider receiving them understands something about the patient. All right, so this is going to avoid lots of errors, lots of oversights. The way I have this presentation done, you're going to see my thought process as I take a history from the patient, and I've got everything marked in colors. The red means something bad that the patient needs to work on. The green is something good. And the bold points, everything in bold is something important, And at the end, I'll give a summary of it all. And then you'll see that the patients are like, wow, I actually got something out of this. You're one of the people in my life that's actually hearing me out. Because a lot of these patients, maybe they come from a neglected household. Maybe they have a trauma background. Maybe that precipitated in some sort of a personality disorder trait, like a borderline personality disorder, narcissistic, antisocial personality disorder trait. Maybe there's substance abuse. That's a very important constellation here. The trauma, the personality disorder, and the substance abuse. A lot of times, these patients will be in an inpatient hospital, and they'll be coined with the diagnosis schizophrenia, schizoaffective disorder, bipolar disorder. Well, that's not it. They may look like that on a bad day, but on a good day, or on a regular day, they're a constellation of the trauma, the PD, and the substance. So this type of history really helps tease all that stuff out. And it's the fundamental of psychotherapy. And I think the providers it'll improve the empathic skills of the provider, and you'll enjoy taking the history and doing the psychotherapy. So this is the long form of the history. I know it kind of looks intimidating. It starts with a history of presenting illness, and that's basically, so Laura, why did you come in? What's going on? What can we help you with? These are the patient's immediate concerns. Then in the past psychiatric history, we have hospitalizations, legal issues, substance, trauma. We got to know some of the medical problems the patients have. Then there's family history, social history. That can be very important. And within there, you've got education, work, marital status, housing. And finally, intangibles. Intangibles is, is the patient well related? Does the patient have these hobbies, these interests? How does the patient carry themselves? The things that don't fall into the above categories, because people are very multifaceted. Okay, so here's the history. And I know it's a lot of writing on the screen, but I'm gonna walk you through this, and I'm gonna decipher the important points when we get to it. Okay. So any questions, any comments so far? Okay, let's jump in. 43-year-old woman, domiciled in a shelter, unemployed, on public assistance, with a diagnosis of schizophrenia, schizoaffective disorder, intermittent explosive disorder. So right now, we got a bunch of diagnoses on the table. We don't know exactly what she has, and we've probably seen patients like this. Laura has been living in the Fulton Market Women's Shelter for the past 6 months after being released from prison for armed robbery. She was incarcerated for 3 years and was released early due to good behavior, since she played the role of a peer support while incarcerated at Jacobi Prison. Laura reports that she heard voices only when she uses cocaine. It was hard for her to differentiate whether these were an accentuation of her own thoughts running very fast or actual voices. So that's an important diagnostic point. If these patients are hospitalized, they're going to get coined with the diagnosis schizophrenia, schizoaffective disorder. So the first thing to tease out here is it due to substance? And in Laura's case, it is. So that's a huge diagnostic help. If we can determine if this patient appears schizophrenic, appears bipolar in the context of substance use. In the case, cocaine makes her look that way. She would also report having heightened amounts of energy, but only during the time when she would be intoxicated on cocaine, while only getting 2 to 3 hours of sleep. That's going to confuse some, even doctors. Oh, this sounds like a manic symptom, but it's due to substance. Could be cocaine, could be crystal meth, could be Adderall IR, 60, 90, that could do these things. She would be immersed in many different activities, such as applying for jobs. She would also call pottery studios because it was one of her dreams to own and run a studio like this. However, she feels that her thoughts are racing and she's thinking a mile a minute. During that time, she also becomes impulsive, irritable, and partakes in some risk-taking behavior. Some people might think this is bipolar, but it's not, because in bipolar disorder, a lot of your activities, you don't have that grandiosity here. They're actually things that she would realistically do and realistically like she needs a job. She's applying for jobs, calling pottery studios. That's not a grandiose stretch of fantasy. She's not, thinking that she's in love with a celebrity or a politician. She's not doing other outlandish things like that. So the context of it all is very important in making the diagnosis, making the patient feel understood. That way, when we're conducting the history, we're actually doing therapy at the same time. We're answering a lot of questions for the patient. And I'm going to expand on this part, the impulsivity, irritability, partaking, and risk-taking behavior. Okay. Fortunately, Laura's been abstinent from cocaine since prior to her incarceration. So I put it in green because this is actually, it looks bad. You know, cocaine use, incarceration, it's actually a strength. She's been clean for a long time. So I put it in green. She reported that she had been unemployed for a duration of 3 years after her divorce, and during that time she's had difficulty securing a job as a graphic designer despite her efforts. So she has a passion for graphic design. She has a passion for the creative. She tried to get a job, but she's having a hard time. Denies suicidal and homicidal ideations. Mental status exam. This is what the clinician sees in the patient. So it's an objective reading, okay? And the pertinent points in here is, look at the thought content. She wants to be more functional. She wants to get a job in a creative industry, such as graphic designer, web designer, pottery studio owner. And she wants to be more functional, so insight and judgment is good. So doesn't really look like a low-functioning schizophrenic patient, low-functioning bipolar patient. She only is this way in the context of her real-life stressors, in the context of cocaine, and the aftermath of the divorce, having difficulty finding a job. Past history. Laura had 2 psych hospitalizations. Both occurred after domestic dispute, where Laura admitted intranasal cocaine use. This proceeded to her behavior becoming erratic, exacerbating the domestic dispute with the boyfriend at the time. Police were called. She was taken to the ER, psychiatrically hospitalized, but she didn't get a legit psych hospitalization. She only got EOB stays. That's an extended observation bed. That means she wasn't there for more than 72 hours. She might have been discharged in 48. That's not legit, organic psychiatric problem. It's not organic schizophrenia. Doesn't meet criteria for, doesn't help you meet bipolar criteria either. So that's an important distinction, the EOB stay. She wasn't there for a week. She was there for 2 or 3 days. So that means it could be characterologic. And in the psychology world, characterologic means something that has to do with trauma, personality disorder traits, or substance. Laura attempted to follow up with psychotherapy, but she only lasted about 9 months. She stopped because she says, I always stay the same. But she did try it for 9 months. And she was applying for jobs. When she got a creative gig, she would stop the psychotherapy. So the rationale, there's a rationale. Why did they stop? Well, it's for something good. She was more functional. She got some sort of working gig, and she stopped. So I marked it in green. That's actually a strength. And she doesn't acquire creative gigs often. And she puts that ahead of psychotherapy. And she's busy applying for jobs. So these are all positives. While growing up, Laura reported she would worry a lot since the age of 13. She was raised by a single mom. She has a younger sister who she's trying to have a better relationship with. She mentioned to her mother that Laura, might need to go to therapy. However, mom never took her to a psychologist, and mom was very busy doing 2 jobs. You're going to hear this a lot with characterologic patients. It starts when they hit puberty. That's because that's when the superego dawns. We see kids all the time running and prancing around without a care in the world, and it's super cute. But when they become a teenager, they're like, what did he think of me? What did she think of me? Is this cool? Am I being accepted? So a lot of people with characterologic qualities, you see it start around that puberty time. Whereas, and that can be difficult to differentiate from schizophrenia. In males, schizophrenia dawns between the ages of 15 and 25, and for women, from 25 to 35, for the most part. So the rationale, the why, is very important. The quality of the thought, that nuance is very important. And if you do an empathic history like that, you will be providing psychotherapy for the patient. You'll be providing healing for the patient just by doing that. Laura reports that when she would break up with a boyfriend in high school, she would cut herself. She had 4 episodes like this throughout the duration of high school. None of them led to a psych. They usually led her to go to the primary care doctor's office. She was bandaged and she was sent home. She was given SSRIs like Lexapro, Prozac, Celexa, but she rarely saw the primary care doctor for follow-ups, and she'd stop taking this medication after the prescription runs out. She'd only get it refilled after the episodes. And when you ask her, she'll say, yeah, when I have an argument with my boyfriend now, it kind of feels like that. So what's the significance of all this? With these characterologic traits, trauma, personality disorder traits, and substance, you're going to see this constellation. The cutting behavior, self-injurious behavior, maybe there's overdosing. It's going to start at that time. That's a borderline trait. Self-harm will manifest in different ways. You'll see these patients on a plethora of medications. They tried like every SSRI because they go into their PMD's office and they say, I'm depressed, I'm feeling sad after this breakup. And that nuance is often not there, even in the primary care doctor's office. And it doesn't really require one to be a clinician to see these traits. So that's why Lexapro, Prozac, Celexa didn't really work for her. And she lost faith in the system and she stopped following it. Last time Laura saw the PMD was during her incarceration. Last blood test showed that she was in premenopause. She's not on any meds at this time. She has a peanut allergy. Family history. Laura's parents got divorced when she was 5 years old. And if you could just get even this one-line medical history, it is beneficial for the next clinic. It will reduce recidivism because some of these patients might have high blood pressure, cholesterol, and that hypothyroidism, which looks like depression, hyperthyroidism, which can look like a panic attack. Just getting a one sentence of medical history, a little bit of family history goes a long way. And the way you can report that, it can be summarized in one line. And that saves the doctors that might be receiving the patient, saves them a lot of time, saves a lot of confusion. Family history. Laura's parents got divorced when she was 5 years old. Her younger sister was 9 months old at the time. Laura's earliest memory, her parents were arguing at home, and she remembers being scared and unhappy. There would be positive moments too. Her parents would take her to the park, and she remembers holding her younger sister and helping raise her. Laura remembers spending a lot of time taking care of the younger sister because mom and dad would be working 2 jobs, or mom would be working 2 jobs, being a medical assistant and also a barista after the divorce. Laura remembers her mom drinking alcohol at home after work, going on dates with different men, sometimes bringing them home to their 2-bedroom apartment. Her mom would have arguments with these men, which Laura witnessed with her younger sister. Laura also noticed her mom's forearms being wrapped in white bandages with some red marks. Why am I giving you all this TMI? And the patient will ask, what does this have to do with anything? The family history is so important. If somebody has schizophrenia or bipolar disorder in their family, chances are there's some remnant of that in the family. Characterologic trait, they're like this, there's some remnant, okay? We see tumultuous relationships with the mother, frequent arguments at home when mother and father were married. We're seeing self-injurious behavior, maybe cutting behavior in the mom. So maybe mom suffered from some borderline traits too. But we don't want to insult the patient with that. A major aspect of psychotherapy is noting it down and waiting for the right time to discuss that. Because a lot of this stuff is really heavy. And sometimes the patients will not know that their mom or their dad might have suffered from these things. So in this field, we can really hurt the patient's feelings. Sometimes the patients can get angry with us, especially the characterologic patients. So tactfulness is very helpful. And what does that do for the clinician? It just helps us in our personal life. It helps us be better listeners in our own life. It helps us be better communicators and be more tactful. Okay. Laura's mother was an immigrant from Vietnam. Dad was American, born and raised in Brooklyn, New York. Laura reports that she would hear stories from her mother, how she and her father would have so much fun in their courtship. They were infatuated. However, presently, and this would make Laura's mom smile, Laura remembers, but later on, Laura remembers seeing her dad only once every 6 to 9 months. She says maybe a couple times a year. This is after the divorce. Her father never met the mother's parents, because the mother's parents were in Vietnam, and they got eloped when they got married. Why is this important? You'll see this with borderline patients, patients who have narcissistic traits as well. The relationship will be a whirlwind. They won't be getting to know each other for that long. You'll see the infatuation. They won't have that much time together. These might be blanket statements, but some of these patterns do exist, and depending how deep the history is, you might acquire more information like this as time moves forward, as you have more sessions with the patient. It's really hard to get this longitudinal history day of the session. So that's what these relationships are like. It's a building process. So mom and dad, we see tumultuous relationship. They knew each other real quick, got married real quick, didn't get to know each other that well. Laura's father came from a working class family, worked hard, rose up in the ranks, had a managerial role at a construction company. Laura's father's aspirations were to run his construction company. He was a hardworking man, and he'd also like to take my mother out. After my mother and father, my mom dated different men. It seemed she would have a whirlwind romance with them. It kind of reminded me of those times, twice a year when I'd see my father. He and my mother would go out, and I would see this whirlwind thing again. They'd come home, and I was helping take care of my sister. So Laura had to grow up fast. We see that the mom and dad, Laura's always remembering holding her sister, consoling her sister. So the mom and dad may not have been present. The relationship might have been a whirlwind. That is what this history reveals. And it also reveals some positive qualities about the father. He's a hard worker. He aspires to own this construction company. Laura reported that she was a mediocre high school student. I didn't get much guidance from my mom and dad when I came to school. She got C's, D's, and F's. After she would cut herself in context of a dispute with her then boyfriends. She reports having 2 boyfriends in high school. After graduating high school, Laura studied graphic design at Baruch College. However, she was in a relationship with an older man at the time. She was 1 year shy of graduating from Baruch when she stopped. Without a college degree, it was difficult for Laura to secure a good graphic designer or web designer job. She was always distracted from school, and she always got emotionally involved with her relationships. So we see the longitudinal history, so the plot thickens. The breadcrumbs start making more sense. And when you're gathering this history, I will say, you may not know who the patient is, but this is always something I remind myself when I got started. I've been practicing psychiatry for about 7 years now. When you're interviewing the patient, it's okay not to know all these details. It's okay to be a little bit nervous. Am I going to be able to understand this patient? The more experience you have, the more the game is going to come to you. When you get to this point in the history, you'll be like, aha, now I'm getting it. Now I'm getting the nuances. And same thing in our personal life. When we're getting to know a new friend or a new partner, the time always tells. Time always unravels the history. If we don't have that time, we won't get to understand the patient. We won't get to understand that person in our life either. So we've got the cutting behavior here. That's when the grades would plummet. Lack of guidance in her academics, because mom and dad were not around. These things will start clearing itself. Didn't precipitate it in not finishing college, even though she's interested in the creative line. Dating older men, because her dad wasn't in the picture. Tumultuous relationships. Laura met her husband when she had a gig as a dancer in a nightclub. She had just gotten out of a relationship at this time. Her husband, Jonathan, was an NYPD police officer. Laura was attracted to his strength, his charisma. He was considerably older than Laura. He was divorced. Jonathan became a local at the nightclub, and they eventually became infatuated with each other. And at this point in the history, you see that history is repeating itself, sort of. You see the patterns of mother, Laura's mom, Laura's dad. You see the behavior repeating. A lot of the histories we hear, everyone is unique, but we will see these patterns. Jonathan did meet Laura's mom and sister before they got married in City Hall. One of Jonathan's best friends and mom was in attendance. Both Laura's mom and sister were in attendance as well. Jonathan and Laura had their first child, a son, about 2 years after they met. Laura became a stay-at-home mom for a period of time, while Jonathan continued to rise in the ranks. Jonathan would come home and he'd tell Laura stories of his adventures as a police officer in the face of danger. He also taught Laura how to handle a gun. Even though Laura loved her son very much, she became restless at home because she wasn't working. Jonathan would spend too much time at work and sometimes wouldn't come home. He would say he's hanging out with his buddies from work, and sometimes he'd stay over at their place. Over the years, they would speak less and less, and there would be more of a distance between them. So here we see Laura and Jonathan's relationship advance, and there's lack of this forthcomingness. There's lack of transparency, and there's a distance that forms. Okay. Jonathan was drinking more and more alcohol after work, and he had cheated on Laura as well. This led to tumultuous fights between the two. They tried to mend their relationship by talking to friends. They thought they could improve their relationship by having another child, so they did. We couldn't afford couples therapy, Laura would say. After they had their second child, things were decent for a period of about 6 months. However, their communication skills didn't improve much, and Laura noticed the same absent behavior, lying, infidelity from Jonathan. The fighting peaked, and Laura eventually filed for divorce. Laura moved out to make ends meet. However, she had not been working for years due to being a stay-at-home mom. She'd have gigs from time to time during this time, nothing very consistent. Laura tried to be a dancer and a waitress at the nightclub where she was employed before, but it was not long-lasting. She didn't find that she had the energy. The loud noise was bothersome, the tips were less, and her cocaine use also increased at the time. During her marriage, because she was isolated, Laura learned how to handle and fire a handgun at the shooting range. Laura had robbed a bodega a couple times during these years because she was having trouble finding a job. She wasn't feeling very good about herself. The third time she was caught and arrested, which led to the current incarceration. So that was kind of a long history. Thanks for sticking with me through this. So instead of the patient having schizophrenia, bipolar disorder, this is a characterologic case of neglect, not having the proper guidance, borderline personality traits, finding a man who has some narcissistic traits, and some substance. Okay, so these are some criteria of borderline PD. And nobody gets there from we all have traits. When does it become a disorder range? It's when functionality is lost. It's when people can't keep a relationship, people can't keep a job, there's risk-taking behavior, self-harm. And narcissistic traits, there is some overlap. People are very self-absorbed. They're entitled. They're interpersonally exploiting for their own gain, and they lack this empathy. They're going to keep doing what they're doing, and they don't understand how it makes the other person feel. And there's different degrees of it. Okay? And you'll see substance use in this constellation. Substance use, people are going to be using this drug in larger and larger amounts for longer periods of time. There's escalation. They use more and more. they use in the context of getting in trouble at work, not being able to keep their relationships. They want to cut down, but they fail to do so. Other people are pointing out that it's harmful, but they have difficulty stopping. Reduction in functioning, can't keep a job, can't keep a relationship. And this is a nuanced category, and this is more in the psychological world. You see these people have attachment problems. There's 4 types of attachment: secure attachment, avoidant, anxious, and disorganized. And Laura might have a constellation of anxious, avoidant, and disorganized attachment. We see fear of rejection and abandonment. The anxious kids, they are, okay, so the easy way to look at this is anxious attachment style is when the parent is inconsistent parent. So the child becomes very anxious. Is my mom going to come back? Is my mom not going to come back? And ambivalent. They're not really sure how they feel, and they're preoccupied and they're worried. Avoidant is when mom and dad, they're even more than inconsistent. They're like not around that much at all. So the child, the avoidant is a little bit worse than anxious attachment. So the child is dismissive. The child is not only anxious, but the child starts avoiding too. So the avoidant attachment is a little bit worse than anxious attachment. And there's disorganized attachment when the mom and dad are yelling. So the child is scared, fearful, and that's why the child avoids. So in the psychology world, we get into these nuances. And then schizophrenia is pretty bizarre. We don't see Laura doing any bizarre things. It's sort of in context. She's having these risk-taking behavior, self-injurious behavior. When she's withdrawing from cocaine, people get very depressed because cocaine will increase dopamine, norepinephrine more than the human body should experience. They're going to feel euphoria. They're going to be on cloud 9, but when they crash, it's depletion of dopamine, norepinephrine, and those are neurotransmitters that help us feel happy, aroused, engaged, focused. But Laura didn't do anything bizarre. She did something violent, but it's not bizarre. And for schizophrenia, it's in the absence of substance. And bipolar disorder, and these last for a duration of time. Bipolar disorder is going to last at least 1 week. And for Laura, we see the erratic behavior, the flight of ideas, only after she does cocaine. So it's not quite bipolar either. So this is the case summary. This is how we can hand off this case in 7 sentences. That's going to help any clinic understand the patient, not have to reinvent the wheel. And it's also going to help the patient find a sense of identity, because a lot of these patients, they think less of the mental health world or the corrections world because people don't know them when they come into a new institution. This is going to help knowing the patient a whole lot more. 43-year-old Vietnamese American woman, history of schizoaffective disorder, but she only has psychotic episodes after cocaine. And she's been in remission. She might have borderline PD. She's domiciled at a shelter for 6 months, unemployed, tumultuous relationships, irritability, emotional dysregulation, self-injurious behavior, only 3 psych EOBs. This history delineates it's not a legit psych hospitalization. Mom might have borderline PD as well. After divorce, Laura couldn't keep creative graphic designer job, partial college completed. Presents after 3 years of incarceration after armed robbery, under the influence of cocaine and lack of a job. So we put into context what happened. She was using cocaine. Okay, she didn't have a job. Her sentence was shortened because she was peer support in prison. She would help some of the inmates, and she had good behavior. She gets child support. She had a 9-month stint of psychotherapy, and she considered couples therapy. So just those 7 sentences really goes a long way. And that's the conclusion of what it means to take an empathic history. You are doing psychotherapy in this process. You are healing the patient in the process. You're helping connect the dots. And as the clinician, as the provider, you're becoming a more empathic person. So it's going to help us in our personal life too. And as a psychiatrist, there's a medication anecdote. Lamictal is a superb mood stabilizer for this constellation of symptoms: trauma, PD, and drugs. You'll see these patients be on copious psych meds. Prozac doesn't work, Celexa doesn't work. But Lamictal has been great. Lamictal tapered up to 150 mg or 200 mg. And naltrexone is a great global anti-craving medication. It's a mu opiate receptor antagonist, and people have been able to strengthen their willpower with naltrexone. People are trying to stay off drugs without naltrexone. It can be hard, but naltrexone can increase the willpower of a lot of people. They can have decreased craving for cocaine, for alcohol, even for opiates. Vivitrol injection is the intramuscular version of this naltrexone medication. And the Vivitrol injection is a little bit more potent than the naltrexone tablet. So this combination will change the patient's life. Lamictal for mood stabilization. It's a great medication to help the patient stop cutting themselves. The narcissistic PD patients, it's going to make them a little bit more empathic. It's going to be easier for you to sit in session with them and actually have the psychotherapy make sense. Whereas before, it's very hard to get through them. No medical conditions, and you list the allergies. So this is a summary. This type of history can improve recidivism. It helps the patients understand themselves. So any questions so far? Any questions, any comments?
So are you in essence saying if they get the proper treatment and we can identify issues, then hopefully we will stop the recidivism and they won't come back to the system? Is that the summation of what you're saying?
The summation is, taking this empathic history, it's like a skill set that has to be cultivated. For a provider to acquire these skills, it takes some time, it takes some practice. I think this is a great way to take a history. This is a great way to get to know another person, a patient, a client. And a history like this uncovers a lot of things, the strengths, the weaknesses, because to prevent recidivism, the top two criteria is work, is education, work. Well, if we reveal to the patient strengths and weaknesses, we can identify what kind of work they should get, what kind of vocational activity. Like Laura here, she loves the creative stuff. We can help her get into a vocational program. We can help her specify which craft she should go into. She should pursue creative stuff in different ways. And that leads to work. And that leads to functionality. So we're reducing recidivism by cultivating this style of history taking. And the patient feels understood, the patient's going to want to come back. And then you're giving them this summary to the next provider, then the patient is even more understood. This is how clinic to clinic, we can all work as a team. We can deliver 7 sentences so the next clinic has an idea what to go off of. So we're not reinventing the wheel.
But in essence, we're just trying to get that person well enough to be able to identify where they want to go in terms of work and education. Because we can't get them well enough to do that, then they will never know if they want to pursue this or they want to pursue that, or even they have the capability of pursuing this, that, or the other. Is that correct?
Yeah, so your point is getting there takes time.
Right.
It sure does.
Right.
It sure does. This is going to take multiple sessions. But for folks that don't have psychotherapy training, if you do this, you will be helping heal the patient.
Yeah, so that was my question about non-clinical, you can still develop these skills, but then are there, like you have with the social history, like are there specific targeted questions that get you to some of those, like the summaries that you have there, like the social, so, like are there targeted questions that you ask that get you to getting some of these things?
Yeah.
Or is it just, you know what I'm saying? I'm assuming you're not just saying what's your medical history. As someone who's not a
Yeah.
clinician, right? Like, are there recommended questions
There
to make
are.
sure that you get
There are.
to these places?
So I'm a psychiatrist who also does psychotherapy. And the way I was trained was this. This was my litmus test. This was the history. When the patient would come in, I'd ask, oh, Laura, okay, I'm seeing you for the first time. So what brings you in today? What can I help you? The patient talks for about 5 to 10 minutes, and we just listen, you know? And then we ask clarification questions. Like, Laura, so when did you start using cocaine? Was this your first robbery? Or have you done it before? How'd you learn how to use a gun? Laura, how many psychiatric hospitalizations do you have? Oh, how long were they? Oh, were they 1 week? Were they 3 days? Laura, have you ever hurt yourself before? Any cutting behavior? Any overdosing? When did that start? It started at age 13. Were you ever married? Yeah, I was. Well, how long ago did you divorce? Oh, it was a few years before I went to jail. So a lot of questions like that, you know? And those that don't have the clinical background, I'm asking a history like this, when you get the hang of it, a lot of the questions are just about being curious about the other person, you know?